Monday. Happy Monday, everyone. It is time for your nursing experience. It's nursing education time. And I, for one, I'm so grateful to be able to start a new day and a new class with you here. And I know you've made sacrifices, whether it's family, work, whatever, to come to the study session. So I applaud your accountability because that is what it takes. As we are living our lives, as we're going through on the pursuit to get this nursing license, we know there's a reward coming, but we just got to stay focused on what our responsibilities are today. And I'm happy to bring this topic to you. It's mechanical ventilation. And the things that I'm talking about, I so wish I would have knew in nursing school because this subject always intimidated me. Why? Because we didn't really have experience with mechanical ventilations. And the reason why it's on our exam is because we will take care of patients on mechanical ventilators. Even though we're not necessarily setting those ventilators, we are responsible because we're the ones at the bedside. Respiratory therapists, they come in, they do their treatments, and then they leave. Nurses are the ones in and out. So we have to understand the principles of how this treatment is going to work. So as I was preparing for this, of course, it came from here. Okay. So if you open your book up to page, I'm going to tell you where you're going to take these notes because there's some additional notes that I want you to add to page 67. Okay. 67. So these are the notes that I have and I'll be sharing with you on today. Welcome everybody. Yes, see, I got people from all over. That's our usual. This is a global community. I don't even have to go into detail about that. You all also know that we are having the bundle deal right now for the three quick facts or the 2 quick facts plus first shift. Now, first shift, I just want to pause and explain. This is my mentorship book. This is everything that I would tell you to be successful when you hit the unit. You actually have to do certain things in order to make your experience as a nurse feel good. Okay. It's a lot of responsibilities, but if you position them the right way, you can get through your first shift. And that's why I wrote the book. So we do have that bundle sale going on. The books are back in stock. Okay. They're back in stock. So let's get into our topic on today. Is the sound good? Everything good? We're ready to go? Okay. I'm going to do a question and answer after the segment. So please just, if you have any questions about anything, write them down and bring them back to the question and answer section. All right. So mechanical ventilation, let me just read it to you. Okay. Mechanical ventilation helps deliver air into the lungs through a tube placed in the windpipe. Okay. So it could be an endotracheal tube or tracheostomy tube. It is used when a person cannot breathe properly on their own, ensuring they get enough oxygen. The machine takes over the work of breathing and helps with gas exchange. Okay. So this is for people who have severe breathing problems. Patients on mechanical ventilation, this is a huge point. They may feel discomfort and pain. So our nursing care and attention is to keep them comfortable so that they can maintain their treatment status on this mechanical ventilator. It is not a peaceful transition. Many people, when they come into the hospital, they will say, you can do everything, but put me on a ventilator. I don't want to be on a ventilator. During COVID, we had a mass number of people who were put on a ventilator. So I think there is even some post-COVID trauma because of the number of people who died while they were on a ventilator. So there are some things that we have to understand about why somebody is put on the ventilator and what it actually is going to do for that patient. I did say that this come from this book. On my version of it, I'm sorry, it's page 67. If you have a different version, a different printout, please put the page so that other people can see the page that we're taking notes on. So Mechanical ventilators, that's what they're supposed to do. Improve a patient's gas exchange. Now, respiratory failure is the reason why someone is not able to oxygenate their body on their own. So any malfunction in the pulmonary system, whether it's in the airways, the alveoli, or the central nervous system, the peripheral neural system, the respiratory muscles, and the chest wall, this can lead to respiratory failure. Shout out to Nurse Shanta. She says, I'm proud to say I'm officially a Remar nurse. I just want to pause for the cause and say congratulations to you. It's a huge accomplishment. You have your nursing license, and I'm really, really glad. And I'm happy that you came back to let us know. Congratulations. All right, this is what we do here. Hi, it's your first time attending. Come on in. We're talking about ventilators here. Okay, we're talking about ventilators, all good stuff. So respiratory failure is a reason why a patient would be on a ventilator. Now check this out. The mechanical ventilation does this, but it does not do this. So the things that it does is it provides artificial respiratory function through intubation. That's what it does. Okay. Respiration, oxygen delivery, and air humidification are controlled by the ventilation machine. That's what it does. What it does not do is it will not cure whatever is going on negatively with the patient. The ventilator does not cure respiratory failure in any way. This is a huge safety point for you as a nurse, because what can happen to a patient is they can be in respiratory failure. The doctor can prescribe mechanical ventilation. Okay. The patient gets put on mechanical ventilation and the oxygenation of the patient starts improving, and the patient is doing hemodynamically better, and the family is getting happy because the patient's levels are normal. But what happens is that apart from that ventilation, the patient would not be doing well. And so there is a very real chance that mechanical ventilation is used only to extend the life while the doctors try to figure it out. But if they never figure it out, then the decision will have to be made. How long does this person stay on mechanical ventilation? And that was the issue with COVID, where patients were put on mechanical ventilation and the doctors were trying to figure out, well, what do we do? What do we do? Okay. And if the patient's body did not respond or did not produce antibodies fast enough, then the decision would have to be made about removing them from mechanical ventilation. So understand that this is not a cure. This is not restorative in any way. There is still a very much a work that has to be done to improve the patient's natural respiratory system. Okay. All right. So mechanical ventilation, we are still talking about it. The indications, why would somebody be put on mechanical ventilation? Again, it is to support the lungs, support that gas exchange, ensuring that the lungs and the oxygen in the blood are sufficient for that patient to continue to live. So anybody that's failing to oxygenate or failing to ventilate. Another thing that mechanical ventilation does is airway protection. And you hear that a lot in the hospitals. Oh, we're protecting the patient's airway. What does that mean? Okay. Preventing, this is what it means. It's preventing it from becoming blocked or collapsing. Okay. Because that air is going to be flowing through. So it's not going to collapse. It also prevents fluids, food, and other things from going into the wrong place, into the lungs. So it prevents aspiration. And we know that is huge because aspiration can lead to bacterial infections like pneumonia. So the indication, this is going to oxygenate the patient and it's going to protect the airway. Now, the four basic components of any ventilator machine, and they're going to look different, but you're going to have a power source, a control source, a monitoring source, and a safety system source or an alarms. And this is what I talk about in the V2. That's the most important thing for you to know. How do the alarms work? The power source is just what it sounds like. It's where the system is getting its power to turn on and turn off. The control is where the settings are done. Okay. Respiratory therapy usually does these for us, but we have to understand them. The monitoring system is where you are looking at the responsiveness of your patient. And the safety system, this is where you're able to determine, are things going good or are things going bad? All right, let's take some notes here because the thing that makes mechanical ventilation so challenging is that there are many ways that you can deliver oxygen to a patient. We know that, right? We can give oxygen to a patient from a face mask, a nasal cannula, a partial rebreather mask. There's many ways we could do a tent, an oxygen tent. It's the same with the ventilator. There are many ways that you can use this machine to deliver oxygen to your your patient. So on your paper, you might want to write these things down because I think in nursing school, this is where I totally got lost because I'm like, what? So let's talk about it. All right, let me make it big again. Okay, so the ways that you can deliver oxygen to your patient is number one, through the tidal volume, right? How much oxygen do you want the ventilator to push out? All right. That's, how much expansion do you want the lungs to have? Or you can do a ventilator rate. Is there a certain amount of breaths that you want to get the patient to experience in a minute? Okay. You can do a rate-based ventilator. You could do a ventilator mode. And there are two ventilator modes that sound exactly how they're named. So you could do a controlled ventilation. Control just means who's controlling it, not the patient, the ventilator. The ventilator is controlling when that patient takes a breath. The ventilator is controlling how fast it is happening, right? So the patient does not get to initiate any breaths at all naturally. The ventilator is doing it all. Okay, that's ventilation. That's controlled ventilation. Assist control is the patient gets to initiate their own breath and the ventilator just supports it so that it's adequate. So you're going to have your patient participating in their breathing. Number 4, PEEP. I never understood PEEP in nursing school. Positive in expiratory pressure. PEEP. All this means, and I wish somebody would have said it. All this means is that at the end of every breath, there is a burst of oxygen. It's like a pop, okay? And that means that it helps to keep those airways open when they normally would be getting ready to collapse, okay? They normally would be closing. So the PEEP keeps the tiny air sacs in the lungs open just by adding pressure at the end of each breath. That's it. So it's a little pop at the end of each breath, a little pressure. That's it. Okay. But naturally, we don't have PEEP. So we have to be careful how high a patient's PEEP is, because if it's too high, okay, if the PEEP is too high, then that can take over, okay? That can cause some pressure to the heart, all right? So it can cause heart failure if it's too much PEEP. So typically it's between like 5, you start at 5 and you go up to 24. Nobody should be higher than 24 PEEP. All right, let me go back to it. All right, so we know PEEP. Now this is the other thing. The FiO2, the fraction of inspired oxygen. Oh, what? People say patient's FiO2 is 93%. What does that even mean? all this means is that this is the percentage of oxygen in the air that the patient is getting. Okay. So if somebody's FiO2 is 95%, then that means that the air that the patient is breathing is 95% oxygen. That's what it means. That's all it means. If somebody's FiO2 is going to be, let me go back to here. If somebody's FiO2 is 70%, then it's just 70% is pure oxygen. Okay. Somebody's FiO2 is 100%, and you're reading a chart. You're like, okay, patient's getting 100% pure oxygen. Patient's getting 98%. The FiO2 is 98%. Goodness, the power of knowledge. Okay. All right. So that's it. The flow rate and pattern is just like it sounds. So the flow rate, this refers to how fast the ventilator is delivering the air during each breath. That's the flow rate. Okay. And then the pattern is what the patient, how they're getting it. Is it normal? Is it fast? Is it slow? That's what it means. Trigger sensitivity is just how much effort is needed for that ventilator to start working. So what is the sensitivity? How much effort is the patient needing to exert in order for the patient to get a breath? All right, I see this question here. I need to define this one. Very good question. I love this question. So let's talk about this. Is FiO2 and SpO2 the same thing? Let me sit back. Is FiO2 or SpO2 the same thing? No, they're not. That's why the names are different. So FiO2, this is the fraction of inspired oxygen. This is how much oxygen the patient is getting. The SpO2, this is the oxygen that's found in the capillaries. So the SpO2 will be in direct relationship to how much oxygen in the FiO2. Okay, so do you see how they work together? If the FiO2 is high, then the patient's oxygenation will go up. That's the relationship we're expecting. So they should have a positive correlation. Does that make sense? So one is what the ventilator is doing. One is what the patient is doing. Great question. This is why I love this class so much, because we are learning based off of what our community already knows. So if you don't have a good question, then there's something wrong, because all questions are good questions. Ask me anything. Ask me anything. All right, let's see. Now, we're going on. We're moving on. Okay, complications of a mechanical ventilation are these medical terms. These are terms that you should absolutely know. Asynchrony. What does that sound like? That sounds like the ventilator is doing one thing, but the patient's body is doing something else. And so they're fighting against each other. They're fighting against each other. Barotrauma. Somebody put barotrauma down in the comments. What is barotrauma? It sounds exactly like what it is. Okay. And yes, if you want to be a nurse anesthetist, this is your bag, because you have to monitor those patients, and you're going to get paid big money to do it. But your patient more than likely will be on some type of ventilator. Okay, so barotrauma happens when you have a ventilator that is way too aggressive for the patient. Your patient is going to sustain some injury because of the pressure, the amount of oxygen even that they're getting. Hello. All right, let me go back to it. Ventilator associated lung injury. It's the same. It's the same. Okay. Hemodynamic compromise. Hemodynamic compromise. If your patient is receiving oxygenation, that's great, but they're experiencing heart failure because of it, or they're experiencing alveoli damage or tissue damage, then that's not going to be great. Nosocomial infection. Okay. We know what this is. This is the hospital-associated infection that the patient gets because they have hospital equipment going into their sterile cavity in their body. sleep deprivation. You're uncomfortable on a ventilator. It's breathing for you unnaturally. Ulcer, gastritis. Ooh, this is a good question. Ulcer, gastritis, malnutrition. What type of ulcers would the ventilator give to a patient? Sheerly based on the fact that this is a new treatment that the patient is not used to, and it is going to make their existence, I don't know, for lack of a better word, it's going to make their body uncomfortable for a long time. Yes, I see it already. Before I can even explain it right. I love it. My people, curlings, ulcers. Patients are going to be under distress. Yes, we are going to expect, and it's going to be true. So if a doctor orders omeprazole, I want to say Prilosec or Pepsi. If the doctor orders that, you know why. It's because this is stressful to our patient. And then overall general weakness. Why does the weakness come in? Why would a patient on a ventilator be weak? And I know this is a lot for a Monday morning. This is a pretty intense topic, but if we do this work, this will definitely make you more prepared. So why would we experience patients becoming weak while they're on a mechanical ventilator? Yeah, pretty much. The muscles are going to start to atrophy because your patient is going to have to be sedated. Very good, Daniel. Very good. Yep. I saw a comment and I can't find it because the comments are coming in so quickly. But someone said what was the term? They said it's dependence on the ventilator a complication. I think that is the goal of the treatment. I think it can turn into a complication if the patient, of course, is not able to be removed from the ventilator. But it's kind of the idea. It's the ventilator is supposed to take off the pressure of the patient's body so that other things can be focused on. Great question. Yeah, you need to get into the V2. This is what we do. This is the best part of our week, Mondays and Wednesdays. Okay, Mondays and Wednesdays. All right, nursing considerations. So here we go. Assessment and monitoring. This is so important. Okay, baseline data, of course, respiratory status, a CBC for the patient, complete blood count. Understand that? Yes, I would definitely suggest passive range of motion, Tiffany. Absolutely. Fluid and nutritional status, you need to understand this. The psychological status of the patient. Are they anxious about this? Understanding the mechanical ventilator settings, at least knowing the definitions of them. Please, oxygenation regarding terms, and then alarm returns. Alarms are going to be more important, I think, because that is when you're expected to do something. Need for suction, airway pressures, positioning, and troubleshooting. Okay, this is, of course, a part of my full program. I do not want to neglect just spending 2 minutes to explain to you that I have developed a full 30-day program for anyone, whether you are a new graduate or you've been out of school for several years. I have the program that is going to give you the lecture content that we're going over now, plus the questions. Both are so important. Both are so important in order for you to feel prepared. The difference is I want to invite you into our community where we have all different backgrounds and we study together, right? So if you failed the NCLEX last month and you're looking for a place where you can come and start over again, this is that place. You will always find us here on Mondays and Wednesdays. I was just joking last week that my mom told me that Christmas was on a Wednesday. So even on Christmas Day, we are going to be here. All right. So get into the program. It gives you books, the online videos, plus the computer adaptive questions. Very unique, very unique. Okay. It's time for the questions about the topic that we have just discussed. And that is the purpose of questions, to really look at what you have learned with your content. All right, here's the first question. Okay. A nurse is assigned to a respiratory care unit. Which of the following findings requires invasive mechanical ventilation? Number 1, moderate obstructive sleep apnea. 2, dyspnea upon exertion. 3, dyspnea with regular breathing pattern. Or 4, adult with a respiratory rate greater than 40. Which one you want to go with? We are talking about the patient that needs the ventilation. And I'm just warming you up. Don't worry about it. The difficulty level will increase of these questions. When you first take NCLEX, you're going to get like a medium question to kind of see where you are. Can you just make sense of medical terms? And I see that you can. All right. Lots of number 4s. Of course, it's number 4, an adult with abnormal respiratory rates. Yes. Okay. Because this indicates acute respiratory failure. Acute respiratory failure. I'm going on to number 2 because you guys got that one right. Here's number 2. Okay. In the mechanical ventilation machine, this part helps the nurse to evaluate a patient's respiratory needs by assessing the ventilator's performance. Number 1, the power source. 2, control system. 3, monitoring system. 4, alarms. Which one you want to go with? Come on in all over. You guys are from all backgrounds, but you have one mind right now. Okay, so this is where the rubber meets the road. And I see a division. I see some 4s. I see some 3s. All right, this is why you come to class. Correct answer is number 3, the monitoring system. The monitoring system. And this is where you're going to be able to assess the patient's performance, okay? How they're doing medically. Okay, now what? Now I'm moving on because I think some of them got that one right. Yes, it's self-explanatory. No. Sometimes these are challenging. Okay, I'm about to cook y'all up now. It's going to get challenging because I gave y'all some easy ones. Now let's try to do this. Here we go. All right. Okay. A patient on a mechanical ventilation has a FiO2 of 100%, and their SpO2 is consistently at 99%. The nurse should prioritize which of the following interventions? Number 1, decrease the FiO2 to prevent oxygen toxicity. 2, increase the PEEP to further improve alveolar ventilation. 3, monitor for signs of hypercapnia and adjust tidal volume. Or 4, maintain current FiO2 levels until the patient stabilizes. Ooh, so good. And you know what? When you understand a topic, these questions on NCLEX is so easy because you have the knowledge. And it's not because you did 100 practice questions yesterday. It's because you spent, let me look at you right now in the face. It's because you spent 5 minutes going over the content and you know the difference of FiO2, PEEP. It's because you spent 5 minutes on content. And this is why I say you can do 1,000 questions a day and fail the NCLEX if you don't do what we're doing right now. I expect everybody to get this question right because somebody from our community specifically asked, what's the difference between FiO2 and SpO2? That was asked today in class and I explained it. So when you see a question like this, every single time, I want you to pick number 1. Patient has an FiO2 of 100%. What's wrong with that? That's crazy work. That's crazy work. I mean, it's going to be beneficial for a little while, but your patient's getting 100% oxygen. Your patient's getting 100% oxygen. They in trouble because you don't breathe 100% oxygen. I don't breathe 100% oxygen. It's mixed. It's mixed up. So we would be worried about our patient becoming oxygen toxic. Oxygen is a medication. You can have too much of it. So I know that looks good, 100%, but what is the oxygen in their capillaries at? It's consistently at 99%. So that means that are they getting enough oxygen? Absolutely. Their body is doing good. All right, are we clear on number 1 now? Let me look. I want to just go back for those of you who picked something different just to see what you picked over decreasing the FiO2, because I want you to look at it and I want you to never do it again, especially if FiO2 is 100%. This is something that NCLEX likes to do to see how deep you have studied. Okay. If you don't understand it, please go back and watch the video again. Okay. Go back and watch the content review of this. All right. And if you are struggling with like content and what do you mean by content, y'all need to get into the V2. Needs to get into the V2. All right. Now let's go on. Let's go on. I said they were going to get difficult. So let's see what else I have for you. Okay, here we go. A patient on mechanical ventilation is experiencing agitation and restlessness. What should the nurse do first? Okay. Number 1, administer a sedative as ordered. 2, check the ventilator settings. 3, restrain the patient's hands to prevent accidental extubation. 4, reposition the patient. Oh, yes, this one is challenging. This is one where you probably can get it down to 2. So you're in front of the NCLEX exam, you can get it down to 2. You gotta pick the safety answer. That's the clue. You gotta pick the safety answer. I see some 1s, 2s, and 4s. All right, Remar nurses. Okay, correct answer. You were right if you picked number 2. Check ventilator setting. You got to check the ventilator setting. All right. Because what is the only way? Well, there's 2 ways that your patient communicates with you. If your patient is sedated and they're on a ventilator, they can't say, hey, my oxygen is dropping. They can't say that. What they can do is they can become restless and agitated. And so anytime your ventilated patient is communicating with you, you need to make sure that that ventilator is not harming them. So this is an instance where, you know how they say a general check the machine. You don't check the machine first. You always check the patient. This is not that instance. You definitely check the machine first here. And this is why I don't really do generalizations for nursing. Okay. You got to check the machine here and make sure that it's not harming your patient. Okay. I'm moving on. Let's go. How we doing? Next question is this. The nurse is caring for a patient on mechanical ventilation. Which of the following interventions is a priority to prevent ventilator-associated pneumonia? All right. Is it number 1, change the ventilator tubing every 24 hours? 2, turn the patient every 4 hours? Or 3, suction the patient every hour. Suction the patient every hour. Or 4, perform oral care with chlorhexidine regularly. What do you guys think? And this is why I love my REMAR nurses, because if I ever get in the hospital, please let a REMAR nurse take care of me, because y'all are going to keep me safe. Okay. All right. Correct answer here is going to be number 4. If you pick number 4, then you know that the oral care is so key, because you have a tube going from the patient's mouth down into their trachea. And so if that mouth is not clean, then that is going to increase the risk of those oral pathogens getting down into the patient's lungs. So that is going to create a situation of a bacterial infection, which we never want. We never want. How did you do? How did you guys do? All right. Listen, mechanical ventilation, I could do a part 2 on mechanical ventilation, because it actually was, to me, more exciting to explain than some of the other topics that we talk about. And I love everything we teach, but this topic today was super fun, because we don't usually talk about it. So I hope that you feel a little bit more comfortable. And then when you go learn about chest tubes and everything else in this workbook, when you fill this one out, you feel like, I have mechanical ventilation down. Okay. I have Monday motivation, and it's coming right from our own community. So everybody, welcome. REMAR nurse. How you doing?
Hi, everybody.
So normally when nurses come on here, they have some wonderful news that they want to share with everybody. They may be watching and they have a test date coming soon, and they're super nervous and they don't think they can do it. What do you want to tell them?
Okay, I'm a repeat test taker. So, V2 quick facts are my best friends.
Mine
Um,
too. Mine too.
yes, I have a short attention span, so I took everything out of your books and I made them as a Quizlet. And I
Okay.
studied them every day until September 12th. When I took my exam, I didn't tell anyone.
Good.
And I found out the next day that I passed.
So when you say you were a repeat test taker, how much of a repeat test taker were you?
It's my second attempt.
Second attempt.
Yes.
So what happened the first time? If you could go back and think about why you weren't successful the first time, what did you do? What did you do wrong?
To be honest, I think I rushed myself. I didn't study fully.
Okay.
Um, I wish I met you beforehand
Sure.
because I didn't remember a lot of the content of everything. So when I got there taking the test, it was just like a blur to me.
Ah.
It was
Did
a
you?
complete blur. And the anxiety and everything just took over me. And I just said to myself, you're not going to pass. And I
Oh.
walked out of there not confident in anything. But meeting you and coming on here every Monday and Wednesdays really helped me. My anxiety completely changed. I walked in there
Nice.
with confidence. I went in there saying, I know I was going to pass. I had the calendar on my door, and I said on this day that I'm going to pass 2024 the NCLEX.
Oh my goodness. Oh my goodness. Thank you so much. I love that testimony. So how long did you study for? Wait. How did you find REMAR? Were you on Facebook? Were you on YouTube? How did somebody
To be honest, I actually found you on YouTube.
Okay.
You
Okay.
came across me on YouTube, and you've been a lifesaver. Your inspiration, motivation. I reconnected myself with God
Wow.
through you. I went back and read every scripture that you would talk about, and it really touched me. Really, really touched me to the heart. And I said, this is the person I need to continue with, because if this person has God in their life, without him, who are you?
Wow.
Yes.
Thank you so much. I needed to hear that. So now that you have your license, or can you talk about can you talk about why you were taking the exam? What are some things that you said to yourself to keep going? Because I'm sure it was still stressful or still a challenge to sit in that room and answer those questions?
It was. They threw everything at me. I could not believe all of my weak areas, which were OB, peds, and mental health, was my exam. They threw everything at me, and I said, God, this is a test, and I'm going to be the testimony. Yeah. And I answered each question to the best of my abilities. And thank God I got all 150 questions.
Oh,
yes.
Oh,
I got all 150. And I walked out of there. I didn't know how to feel. I felt numb. And my good friend, she said, rest, and you're going to get the best news in your life. And when I woke up the next morning, I received the email that I passed.
Amazing. That's phenomenal. So I can actually say, and I think you can agree, you earned that license.
Oh,
like
yes. I've been through a lot. I have a daughter with special needs. So we've been in and out of the hospital. And throughout my time in nursing school, I literally lived in a hospital with her. And she was my motivation. And my aunt, who passed away unexpectedly from a brain aneurysm, is my reason of wanting to become a nurse.
God bless you. God bless you. And I'm so grateful that your daughter has such a great mother who is providing awesome care for her, because that's a blessing. That's a blessing that you're able to do that for her. So tell me now, what will you do now that you have your RN?
Right now, I'm currently applying for positions, and I'm just waiting for a callback.
An opportunity.
Yes.
Oh, man. And there's so many out there, and I think you'll be able to spend more time with your daughter. You can, choose when you want to work, when you don't want to work.
Yes.
I just see you having so many opportunities now with because you have a special circumstance. You have a child that you really have to be mindful of.
Oh, yeah.
And so now you have a career that will allow you the flexibility to make your own schedule and work when you want to, so you can be there for your baby girl. And I am just so grateful. I'm so grateful.
I owe you a lot.
God is good, girl.
Content is what it is. Content. And when I tell you, I even had one of my friends, I introduced her to you as well. And she got the V2 program, and she also passed on August 28th. Yes, she did. Her first attempt.
I said congratulations.
Yes, I will.
Thank you. Oh my goodness. So you just have so much to look forward to. And I'm just so grateful that you came on here and let us know that it's possible. When nursing school is difficult and challenging, if you look at the people that are depending on you, you can do this.
Oh, yes, you can.
Thank you so much for coming on. I hope you have an amazing week.
Same to you. You guys can do it. All of my Remar family, you guys, your support, your motivation in the chat, everything. You guys are next. Okay? 2024, you guys are going to be Remar nurses as well.
Oh, thank you. Bye-bye.
Bye.
You guys, what a beautiful testimony. It is not easy having a child with special needs. It's not easy having a child. It's not easy having a child with special needs that requires hospitalization and you being there. Because when you're there with your child, then that means you can't be in nursing school and you can't study, all the time. So praise God, the V2 was able to be integrated into her busy life. And the best news ever, y'all. The best news ever. She said she reconnected with God. And I'm telling you, God is your strength through this process. You have to believe that. It's time for Monday Motivation. Doubt kills dreams. And this is for me. I hope y'all just listen to this is my motivation to myself this week. All right. So how do we make our decisions? How are we making our decisions? Let me just ask you. And I want you to be totally transparent, because this is where I am. Am I making my decisions based on how I feel? Based on people's advice? Are you somebody that does research and analysis? Or are you somebody that tries to make decisions based off of like your values, your beliefs, what you think is right or wrong, or even what other people are doing? This is so key, how we are making our decisions, how we are setting up our goals, because James 1, hear me, James 1, 6-8 says, but when you asked, you must believe and not doubt, because the one who doubts is like a wave of the sea, blown and tossed by the wind. Oh my goodness, Lord. Why'd you say that to me? Why'd you say that to me, God? That's just how I felt when I was doing this motivation. Oh man. James 1-6 is saying, the person should not expect to receive anything from the Lord if you are a doubting person. If you're like, God, I know you can do this, but at the same time, you don't really believe it. You're unstable as the waves, as the wind. You are. This is me. This is me. This is me today, y'all. And I just have to be transparent, because since forever, people have been saying, well, why don't you start a school? You got Remar. Why don't you do a nursing school? Everywhere we go, why don't you start a school? And I get so, it's just like when people ask me this, I be like, because I can't start a school. It's too much. I don't know. I can't do it. Right. And I was talking to Mark last night, and I had this meeting set up. Anyways, I went to this conference. I met these people, and they're like, oh, we help people start schools. And I'm like, okay, cool, God, because people keep talking about me starting a school. And I have the meeting set up with these people today. And then the lady emails me this morning and says, oh, we have to cancel the meeting. And I'm like, oh, well, see, God, I wasn't supposed to start this school. And I'm in my prayer before I start this live. And I hear God say, the meeting was canceled, Regina, because you did not believe that you could do it. You're not ready for the opportunity. That's why I canceled the meeting. And I'm like, oh man, like I messed up. Like, I'm like, God, I'm so sorry. I didn't believe, like I didn't believe. And so I'm sitting there literally before this live starts. I'm bawling my eyes out because I realized that I didn't have the faith to even take the meeting. And so God took the meeting away from me. And so I'm sitting there and I'm like, God, I'm so sorry. I don't know how I'm going to do this. And he's like, get up. There's people waiting for you. You still have to be a testimony that God is good. And he was like, and I'm like, no, God, I don't want to do it. I don't want to do it. I'm not like, I'm sitting here having an argument. And meanwhile, it's like 5 minutes before this live to start. And I'm like, God, I don't want to do it. He's like, get up. There's 800 people that's going to be waiting for you to do this class. You're still going to be obedient until you have faith. And so God, when I'm just like, God, man, you got to help me get there, because I didn't have the faith to even think. And I don't even know how it's going to happen, but I must believe that this school is going to take place. And God is going to make a way for me to start a nursing school. And I don't have to believe it. I mean, I don't have to understand it to believe it. I just have to hear God and walk in faith. So when I tell you guys that these Monday motivations in these classes literally help me, they literally save me, they do. And just as much as you guys wait for Mondays and Wednesdays, so do I. And so when I read this, I'm like, yes, Lord, this is it for the week. Like, our takeaways: do not ask for God's wisdom and then act in your own. That makes no sense. Okay? If we want God to do something, we have to rely on his wisdom. The second one is asking in faith refers to being fully convinced that what God has promised, he is able to perform. Okay? And the double-minded person is also the one who relies on self during the good times and quickly turns to God during the bad times. And that is what we don't want to do. Okay? When things are going good, we're like, oh, it's me. And that's what I never want. Never want that. Okay? So when people come here and they say, oh, Regina, you did, no. God did it. It was God, right? And that's how when people come to you and they're like, oh, you're such an amazing nurse. You helped me. You saved me. You got to say, God is good. God did that for us. You know what I'm saying? Because we always have to draw the attention and that light to God, because that's our source. Ourselves, we are nothing without God. Whatever little we can accomplish on our own, it's just here for a moment. But with God, what you do will last for generations. That's the beauty of it. That's the beauty of it. So this week, your testimony is that you are believing in God even when you can't see it. What's this one? Something says, oh, God is the source of wisdom. Proverbs 2:6. I want to look at that one. What else do we have? Philippians 4:13. I love it. I love it. Thank y'all. Thank y'all. Y'all testifying and preaching. All right. That is just where we are. You know, we are always growing by God's grace. We're growing in our faith, and we have his grace when we don't get it right. When we don't get it right, God is still there giving us a work to do. And that's why nursing is such a ministry, because when you are a nurse, you truly take the focus off of yourself and you put it towards somebody else. And you get to become the hands and feet of Jesus when you do that. And so when we are even pursuing our own goals, we have to think about, how am I using this to serve man? How am I using this to do that? So God bless y'all this Monday. Whew. It was a good one. All right. And we have another class coming on Wednesday. Oh, I also need to come on here and do a live. I'll probably do it tomorrow because the NCLEX conference was on last Thursday. And so I want to, or was it Friday? I can't remember. I think it was Thursday. We have to go over the updates and the things they talked about at the conference. You know, they do a conference every year and they tell things about what you should be looking for, things like that. So I want to share those notes with you. I'll probably do it tomorrow, but I hope you know that I love you very much. I thank you guys. Y'all saved me today. Y'all really did. So thank you for coming to class, and I will see you on Wednesday. And if nobody told you this before, you can, you will, and you must pass NCLEX.